I'm excited to share yet another study that, for me personally, has been pivotal in understanding how I assess patients with extremity pain. And it really looks to ask the question, what percentage of people who have symptoms in their extremities, which is their upper extremity or their lower extremity from their hip down to their foot, that are coming from the spine? And we can get a little bit into the weeds with the terminology we use in that situation, coming from the spine or emanating from the spine or from a spine problem. We could also just say fixed with spine movements. I'm very comfortable saying that these problems are coming from the spine. And to me, that means that the root cause of the symptoms and signs in the extremity are due to a problem that's the root cause in the spine. But that's the main focus of this study. And then secondarily, it looks at the outcomes when it comes to patients who have extremity symptoms that are diagnosed as spinal problems versus extremity problems. The title of the study, a study exploring the prevalence of extremity pain of spinal source. And they've kind of abbreviated the end with XBOS, extremity pain of spinal source. It was published in 2019 in the Journal of Manual and Manipulative Therapy. Richard Rosedale et al. Were the authors, and they had 4 clinics where they looked at patients who had presented with extremity pain as their primary complaint, and for whom neither the patient nor if the patient was referred by another doctor, neither of them believed that the source was in the spine. Now, that's not excluding people who present, for example, with knee pain and also their back aches from time to time. We're not excluding those people, but we are excluding the people who come in saying they have knee pain and, yeah, I think it's from my back, or my doctor who referred me here thinks it's coming from my back. So that's an important exclusion because we're really focusing in on the people who don't think that there's any relationship with the spine. And when we're talking about upper extremity symptoms, shoulder down to the fingers, we're talking about primarily the neck, but it could also be the mid-back. And for symptoms from, the buttock down to the toes, we're talking about the low back, but in rarer cases, that could also be something emanating from the mid-back, the thoracic spine. So one of the thrusts of this study, and one of the reasons they did it, was because, as they point out, there is no documented process for how clinicians figure out if the root cause of an extremity symptom and signs usually is coming from the spine. I think, and I could be wrong, I think what I learned in my doctoral program was you move the spine in several directions, and if it doesn't recreate with that 1 or 2 movements the patient's shoulder or arm, elbow, forearm, or hand or wrist pain, then you've cleared the spine. And we use terms like clear the spine or a spinal screen or screen the spine, but we don't have a cohesive understanding or definition of what that means. Unfortunately, patients with orthopedic complaints or complaints in the extremities, if you go to different orthopedic clinicians, you will get different evaluations and therefore different diagnoses and therefore different treatments. We are definitely not on the same page, which I think in many cases is to the detriment of patient care. But then again, I think there are clinicians who are doing it very well, so that does help patients. But we do not have an understanding of how to screen the spine. So we would love it if there were one process that all clinicians kind of understood, like, this is the process for me to figure out whether or not someone's hip pain is coming from the hip joint or the spinal joints in the low back or something else. We don't have that cohesive understanding. Sometimes people rely on imaging. So if there's a picture of the low back or the neck and they find something there, they're more likely to call that the root cause. We know that imaging is fraught with problems. Sometimes people use baseline testing or quick orthopedic special tests to make their diagnostics. However, MDT, Mechanical Diagnosis and Therapy, has a very specific algorithm that is the backbone of what I do, which is in essence helping us diagnose the root cause first, starting with location. what is the location of the problem. It can be quite distant from the signs and symptoms, but that's how we start our patient care, is location first. So it's location, diagnosis, direction, and force for most people when I'm thinking about my patient care kind of sequence. So ask a clinician how they screen the spine, you'll get different answers. And I also think screen the spine or clear the spine are a little bit too, not only vague, but too timid, right? Because so many people do have problems in their spine that this almost makes it sound like an afterthought. Like, oh, just clear the spine. How do I clear the spine? Well, I don't call it clearing the spine. I call it doing an orthopedic evaluation, which, because I know prevalences, does not make me think the spine is an afterthought. It makes me think the spine is a front runner in almost everyone's problems. So it starts with the specific verbal history that for someone with knee or foot pain, I have certain questions that I'm asking in my verbal history to help me gauge, is there a possibility that the problem is not local, that the problem is in the spine? And then it's taking orthopedic baselines. And for me, again, someone with a shoulder or an elbow complaint, I am taking spinal baselines. And that's not something I learned robustly in school. And I don't think you're going to find the majority of clinicians in the US are doing that, taking real baselines of the spine for just elbow pain, right? Or just wrist pain. And then thirdly, repeated movement testing, right? So that is where we really, the rubber meets the road. We really figure out if what we heard in the verbal history and what we saw in the baseline, taking range of motion, strength, nerve tension, and functional baselines, is actually changeable with certain movements in the spine or in the extremity joint. And that's kind of just the test, assess, retest baselines approach. It's not rocket science, but it's not well implemented in the world of orthopedics in the US currently. So let's go back to this study. They looked at patients at 4 clinics, Canada, New Zealand, and the United States. Again, the patients nor the patient's referring doctor, if there was one, believed that the problem was due to a problem in the spine. They excluded people who were post-surgical patients, inflammatory conditions, recent trauma, and neurological disorders that would kind of preclude them from going through this process. This is an important point. The clinicians that were used in this study, 2 were diplomats in MDT, using repeated movement testing, who were also instructors with the McKenzie Institute. 1 was a diplomat and 1 was certified. So again, there's 2 levels of training using MDT. Becoming certified is the basic level. Becoming diplomaed, which I am, is the higher level. And I hear the argument that this is not generalizable because most clinicians are not skilled in MDT. And is that a barrier to kind of entry? Absolutely. I would love it if we learned this in school. I would love it if you had a couple classes over the courses of 2 or 3 semesters that were just repeated movement testing. How to do it for elbow complaints, how to do it for knee complaints, how to do it for neck complaints, etc. I think that would radically change the orthopedic care in the US if people came out of their MD, DO, ATC, DC, and DPT programs, among others, maybe nurse practitioners as well. If people who saw patients with orthopedic complaints who wanted to give advice or diagnosis knew repeated movement testing, I think that would be transformative. But most people don't. So those are the exclusions. That's the level of training of the clinician. So very high level. Some studies that look at MDT are having the clinicians who use MDT, those clinicians are not very highly trained. And I think that can be a limitation in those studies. So when I read studies about clinicians using MDT or repeated movement testing with patients, I really want to understand how well are they trained. And that can be a barrier for lots of different things, right? You can't be poorly trained at kind of chemotherapy and expect great outcomes compared to people who have been doing it for years and are highly trained in using that treatment intervention. So how well the clinician understands the assessment process is really important. They looked at 322 patients, and the end result was that of the 322, 140 of those patients with extremity symptoms were resolved with moving the spine. Again, the verbiage can be a little bit tricky. I'm happy to say their problem was coming from the spine. So that's almost half, 43.5% of these patients. And importantly, because the secondary part of this study was to look at outcomes, spine versus extremity disorders, of those 140, 139 that were coming from the spine were classified or diagnosed as joint derangements. And joint derangements respond rapidly. That's part of their definition, basically. Some slower than others, but I expect a joint derangement on average to be fixed quite faster than a tendinopathy, right? Or of course than a frozen shoulder or a muscle tear or recovering from surgery. So that's why it's not only important to get the diagnosis right, of course, because it informs the care, but if you get the diagnosis right more often, you're probably going to get people better faster because of the nature of joint derangements, which are resolved by finding the direction that joint needs to get back on track, so to speak, and having the patient move that joint repeatedly into that direction. And crucially, very little manual therapy is needed. Most times I can just teach patients, you need to do neck retraction extension in supine, or you need to do lumbar side glide on the wall, and I'm not needed. I'm needed as the teacher. So that's the big takeaway, is that a huge proportion of this sample size, which is small to be fair, but a huge proportion had problems resolved with moving the spine, and almost all of them moving the spine into specific one or two directions. And clinicians who are not using MDT, who are not using repeated movement testing, are they finding this amount? No. There's not literature on some of these joints, and the literature that does exist on some of these joints does not find such a high prevalence. So when we parse it down to the joints or places in the extremity, when they looked at hip joint symptoms, it was 71% were from the spine. Knee was 25.6% from the spine. Ankle, foot, 29.2% from the spine. Shoulder, almost 48%. Elbow, 44%. Wrist, hand, 38.5%. So again, these are the percentages of the patients with these complaints who had their disorder resolved by moving the spine. And when we look at the non-joint parts of the extremities, so the thigh and the leg. The thigh in medicine is the part between your hip and your knee. So the thigh, the leg between your knee and your ankle, most people just call it the leg or the lower extremity, but in medicine we're specific. So the thigh and the leg, if patients presented just with thigh pain or leg pain as their primary complaint, 72.2% of them were from the spine. And that, I think, is more common knowledge, that outside the joints, if it's in the tissue between the joints, it's more likely referred from the spine. And that was borne out in this study. And when it comes to the arm and the forearm, it's 83.3%. So if someone complains of just arm pain, it's spine unless proven otherwise. Same with kind of the thigh and the leg. So what we can best hypothesize as to why it's there is because of somatic referred pain. So visceral referred pain is when you're having like a heart attack. One of your organs is referring pain into the upper extremity or into the jaw. And kidneys can refer pain. All your organs can refer pain. And tissues can refer pain to other places as well. So problems in the spinal tissues, something going wrong in the spine, can send pain into the extremities. And this study was looking at primarily how different it can be when we think about just joints, because so often people think of shoulder pain as definitely coming from the shoulder. Wrist pain, ankle pain, definitely coming from the wrist and ankle. And this study at least proposes a reason to question that narrative. It's not set in stone because we need to replicate studies like these, but it gives some credibility to actually what I see all the time. Because I do repeated movement testing, this is what I see. And I'm not always doing spinal repeated movement testing first, because I use the information in the specific verbal history and the baselines to inform where I start my repeated movement testing. But I recommend to people who are learning repeated movement testing to always start there, to have a very clear funnel or algorithm, so to speak, just so you get clarity in the orthopedic evaluation For me, I'm starting where I think it's most fruitful. It's almost always the spine, but sometimes in rarer cases, I'll start strictly with extremity movements. So in terms of the secondary part of this study, they wanted to look at the different outcomes. I'll briefly touch on that. When they had the patients with extremity pain that were diagnosed as extremity disorders, which was not only joint derangements, but I'm assuming also some tendinopathies and maybe some structural lesions. I'm not quite sure. They didn't go into that in the study, but they were discharged at 6.4 visits on average. And the patients who had extremity pain that was resolved with spinal movements on average had 5.5 visits. And that speaks to likely the fact that 139 out of 140 patients who had problems in the spine had a diagnosis of joint derangement. And again, those are usually more rapid responders than other diagnoses. Also, when we compare the patients with spinal disorders versus extremity disorders, just those bigger buckets, the patients who had spinal disorders had better results when it came to the pain questionnaire, the upper extremity functional index, the lower extremity functional scale, and the psychosocial scores. Again, that probably speaks to the fact that derangements are more readily fixable. So what this also highlights for me, and that the authors point out, is if I read a study and we looked at 500 people with elbow pain and found this, I'm asking myself, did they exclude patients or did they look for spinal sources for those patients? And the answer is almost always no. So I take those studies with a grain of salt because I know from my personal experience as a clinician for over a decade and from studies similar to this, that so many patients who present with elbow pain, you can resolve it by moving their spine on average with just a handful of visits. So other studies are saying possibly kind of in a vague way that they screened the spine or they cleared the spine. But again, what does that actually mean? There isn't a formula that we're all on the same page with. So when I read those studies, and I encourage other people when they read those studies to be like, well, did they look for a spinal source for the patient's knee pain? Because if they did, then they would likely be resolved much more quickly and obviously with different treatments. But say you take 1,000 people with knee pain, and if you did that in this study, at least 250 or so would probably have spinal sources. So if you took those 1,000 people and some are not resolving at all, then they might get grouped into, well, some tendinopathies take longer than others, or some patellofemoral pain syndromes are more challenging than others. And I would counter that and say, well, if you got the diagnosis right, maybe you wouldn't find such a wide spectrum of treatment effectiveness with these disorders, because some of those were actually lumbar derangements in most cases. So that calls into question, again, that other studies, I take them with a grain of salt if I know that the authors have not even really dived into figuring out the location first. So test, retest. That's the essence of this. You take your extremity baseline. So if the patient complains of shoulder pain with or without contemporary or historic neck pain, I'm taking the shoulder baselines. Range of motion, strength, nerve tension, which is more a spinal sign, but I might take that, and a functional test. Like it hurts when I lie on my shoulder. It hurts when I do a push-up. I'm taking the symptoms. Does it hurt right now? When does it hurt? And then obviously I'm taking the spinal baselines as well. But those are the pertinent baselines that we care about, because I don't want to see if the spine changes the spine. I want to see if moving the spine changes the shoulder. So I take the shoulder baselines, I repeatedly move the spine, I pick the direction that I want to start with. It's almost always in the sagittal plane, unless there's an obvious physical deformity. I'm starting in the sagittal plane. Based on the specific verbal history and the baselines that I've taken, I decide where to start my repeated movement testing. So say I start with just retraction, the patient does 10, 20, 30 retractions, I retest these shoulder baselines at increments that I see are appropriate, looking for a change. Take baselines, do the repeated movement, retest the baselines. It's very cause and effect. It's not very woo-woo. It's really looking at changes. And if people see that change and it carries over between visits, they start to understand that, oh yeah, moving my neck, getting my neck moving better is really influencing my spine, or I'm moving my neck is feeling a little bit better and looser, but nothing's changing in my shoulder, then I can move on to something else, maybe a different movement of the neck or mid-back, or maybe looking at the shoulder itself. Again, that's an algorithm that a clinician has to learn. There are obviously rules, but clinicians might get there a little bit differently, but we're gonna get to the same spot if all of us are using MDT at a high level. We might do a little difference in attacking in supine or prone or manual overpressure or mobilizations, etc., but we'll arrive at the same diagnosis. There's reliability when it comes to low back disorders. We need more studies that show that reliability, for example, with the shoulder. But when I speak to colleagues, we are arriving at the same conclusions when we use repeated movement testing well. So my big takeaway for patients who are suffering with extremity symptoms and clinicians who are seeing these patients, try to learn repeated movement testing. I think you'll be pleasantly surprised how much more enjoyable it makes your job as a clinician, because you're seeing relatively rapid changes. If 5 visits, I think, is ahead of the curve when it comes to symptoms, especially when their symptoms are chronic. But again, going back to the patient side, you can buy the books by Robin McKenzie that are geared towards the layperson and self-assessing to see if your symptoms are coming from the spine. Repeated movement testing, one day I hope will be taught in school so that we can all use it correctly, to really start again with, before we get into the diagnosis and the treatment, let's first start with the location.